if a lesion is found on MRI, you obviously have to biopsy. You can do an in-bore biopsy, which we all know probably ties up the MRI, takes time, things like that, or you can do a cognitive or fusion biopsy. So it's putting it together with ultrasound, either transrectally or transperineally.
Mm-hmm.
How do you? What are your thoughts about that? Does a urologist in the United States need to go out and buy a couple $100,000 fusion device, or can they do pretty well by doing cognitive biopsies and maybe an extra 2 biopsies or so?
What most important is that experience matters, is how much experience do you have as a urologist with MRI? How confident are you in reading the images? How good are you in your brain to match the 3D image on the MRI with a 3D image on ultrasound? If you're not able to do that, and it needs education to be able to do that, when I see an axial slice of the entire body, I can reconstruct in my brain the coronal slices, and I see the patient in 3D in front of me. That took a lot of training. And if you don't feel confident with that, don't start with cognitive biopsy, or ask your radiologist to help when he is good in ultrasound. So, if you are not good in that, fusion technology definitely will help you. You should be also aware about the limitation of fusion. There is a fusion inaccuracy, which is inherent to the technique. And the newer the fusion technique is, the better it gets, but there is a slight error. And that is when it really is a small lesion at a different location, like the apex or the basis, then in-bore biopsy is the best technique. Refer the patient to an institution that is able to do that. You don't need to do it yourself. And it's only just a few patients. In our institution, we more or less combine that. We have a multidisciplinary team of urologists and radiologists. We discuss the images, and all the persons who are doing the biopsies are there. Urologist is fusion, radiologist is in-bore, and we discuss what would be the best for this patient. And then we come to a conclusion. And also we look in how confident are you in hitting the lesion. Say, well, it's difficult. I don't feel confident. Okay, and then you choose for in-bore. Roughly less than 40% in our institution is in-bore, and the others are fusion. Talking about fusion, we use a combination of cognitive and fusion. So what we do is we have a technique where we see the MR with some real nice structures that we recognize. We call them the markers, like a BPH nodule. Then we overproject the ultrasound, and we are matching the structures we see. So there's also a visual part. And then we zoom in. We do the same, we zoom in, we do the same, we zoom in, and then we are at the lesion, we stick in a needle. More or less with cognitive fusion. So it's a cognitive fusion technique, which is pretty good. In my talk, I already addressed the fact that 1/4 of the lesions are visible on ultrasound when you have seen the MRI. And, sorry, it was 3/4 of the lesion. And even if the lesion is more aggressive, you tend to see it better on ultrasound. So then you don't need the MR that much. So what I would advise is look at your MRI and then decide with your radiologist and urologist together what to do.
So if I was, that was very good. If I were sort of summarizing and doing the take-home messages like we do at a lot of meetings, I would say the important points are multidisciplinary team looking at the individual patients and the films and so forth and making sort of a decision, which we don't do a lot in the United States. So I think that's important. The second thing is how comfortable you feel with ultrasound and how many you've done. I know I feel pretty comfortable. I started in the mid-'80s doing ultrasounds with, you know, some of the old machines that were A and B modes and things, and we've come a long way now with micro ultrasound, which is the next thing I want to talk about, which is 29 megahertz. You can see things that you can. So I think it's what you said, it's a team effort. Go over it with your radiologist, anybody else you're going to work with, and then how comfortable you feel with fusion or cognitive biopsies.